Hello, Dr. Rockhold again. This will be the second of the 4 segments on antidepressant pharmacology. In it, we're going to talk a little bit about the history of antidepressant drugs, but also the major hypotheses that we have concerning how these drugs may actually work in managing major depressive disease. So, what causes major depressive disease? Well, we're not entirely sure, but from the introduction of the first effective antidepressant agent, ipranisib, in 1951, there have been strong suggestions that the monoaminergic systems in the brain are disrupted. As the cartoon suggests, mood and its associated affect have components that can be associated with the action of separate monoamines. And as we'll see, the link to monoamine function is strong, but it's not the complete picture. It's challenging to link monoamines alone for some of the manifestations of MDD, particularly including the remodeling of neuronal connections that occurs in critical brain regions like the amygdala. The involvement of neuronal growth factors like brain-derived neurotrophic factor, or BDNF, in synapse formation and plasticity have led to a neurotrophic hypothesis. And then finally, there's been a recent recognition of antidepressant agents that work much more rapidly, have a much more rapid onset of action than the traditional antidepressants. And these are agents like the NMDA glutamate receptor antagonist ketamine. That recognition has introduced new aspects to the mechanisms that underlie the action of the antidepressant agents. The origin of modern antidepressant pharmacology occurred serendipitously in the early 1950s. A novel anti-tuberculosis drug, ipranisib, was tested in patients who were sequestered in a New York State tuberculosis facility, and they weren't very happy. A media frenzy followed after introduction of the use of ipranisib for tuberculosis, which was rampant in those facilities. And it was recognized that patients became much more active, they were less depressed, and reportedly dancing around in the facility. Soon, it was discovered that ipranisib was also an effective inhibitor of monoamine oxidase. Following the introduction of ipranisib, and until recently, we can see that the development of antidepressants followed 2 major trajectories. Phenelzine was arguably the first clinically effective MAO inhibitor, or MAOI. And from it sprang agents that were selective for the MAOA isoform and irreversibly inhibited the enzyme. Additional agents along this track, like moclobemide, which have more transient reversal effects on MAO inhibition, followed. On the other track, imipramine, the first of the tricyclic antidepressants, or TCAs, was identified early as having antidepressant activity. Only later was it found to inhibit reuptake of norepinephrine. And even later, it was recognized that another monoamine, serotonin, was linked to depression, and the selective serotonin reuptake inhibitors, or SSRIs, like citalopram, Celexa, were found to be very efficacious. Selective norepinephrine reuptake inhibitors, the NRIs, serotonin and norepinephrine inhibitors, SNRIs, and then the serotonin modulators and stimulators, SMSs, have been subsequently introduced. On separate trajectories, much more recently, agents with more complex actions like bupropion and mirtazapine have followed. And then most recently, in the last few years, agents that exert antidepressant agents within hours to days rather than requiring an onset duration of several weeks, like ketamine and brexanolone, have been introduced. Recognize that generally speaking, as we ascend this developmental ladder, adverse effect profiles tend to diminish. However, there have been only limited improvements in the overall efficacy of their antidepressant effect. But reduction in adverse effect profiles is a significant accomplishment. The experimental underpinnings of the monoamine hypothesis for MDD began with the use of high doses of the adrenergic blocker and monoamine depleter reserpine for treatment of hypertension. Those treatment regimens were associated with increases in suicidal depression and in suicide. Progressively, the effects of MAO inhibitors, tricyclic antidepressants, the SSRI and the SNRIs, and all of the antidepressants, except the newest fast-acting agents, have been linked to interference with monoamine neurotransmission. All that makes sense for a monoamine hypothesis. The most obvious challenge to a purely monoaminergic rationale for antidepressant actions is the discrepancy between the onset of antidepressant effects, which for traditional antidepressants often requires several weeks, and the fact that significant neurochemical changes and the onset of distressing side effects often occur within hours to days of beginning treatment, leading to serious questions about the discrepancies. The neurotrophic hypothesis recognizes that depression is associated with a reduction in neuronal connectivity, particularly within the limbic system, and a pruning of both synaptic boutons and arborization of dendrites in those systems. This can be associated with a reduction in serum levels of brain-derived neurotrophic factor, BDNF, which is reversed or enhanced by treatment with antidepressant agents. The time course of increases in BDNF serum levels correlates well with the time course of clinical response. Recently, 3 uniquely rapidly acting agents, the NMDA receptor blocker ketamine, ketamine's S-positive enantiomer, S-ketamine, and brexanolone, a neurosteroid progesterone derivative that allosterically enhances GABA-A receptor transmission, have been introduced. This has required reassessment of the basis for antidepressant actions. What we can say with confidence is that depression alters neurotransmission in the limbic system, and antidepressants through monoaminergic, glutamatergic, and GABAergic mechanisms enhance and restore neuronal plasticity and responsiveness. The details of this cartoon, again from a recent Lancet Psychiatry article, summarize a current comprehension of these actions. Enjoy the cartoon, but recognize that you will not be asked to reproduce any of the details. It's important to realize that traditional antidepressants have very different profiles of effect on multiple monoaminergic and cholinergic systems. These actions can be linked to clinically relevant adverse effects. A couple of examples. The atypical agent, mirtazapine, is a very potent histamine H1 receptor antagonist. As you can see from the association of the graph with the cartoon below it, the prominent side effects of somnolence and weight gain reflect that antagonism of the H1 receptor. Similarly, the SSRI Prozac, fluoxetine, inhibits neuronal serotonin reuptake, and this is reflected in stimulatory behavioral and somatic symptoms. In summary for this segment, expect that management of drug-induced side effects that will be a significant component of helping your patients through their therapy. Patience and a thorough understanding of the relevant pharmacology of each agent is needed. In general, these agents are dirty, dirty drugs. In the next segment, we'll go on and we'll begin to look at the traditional, older antidepressant agents. Thank you.